one and all present here. I am Dr. Ipshita Burman, is here to present on the topic Indocyanine Green Enhanced Transpupillary Thermotherapy versus Transpupillary Thermotherapy for treatment of thicker tumors in retinoblastoma, a randomized controlled trial. So coming to the introduction, retinoblastoma is the most common primary intraocular malignancy of childhood, and the focal treatment includes laser photocoagulation, transpupillary thermotherapy, cryotherapy and brachytherapy. So TTT is a subphotocoagulation heat treatment using the infrared radiation from a diode laser which is directed at each tumor. ICG is a green dye that binds tightly to the plasma proteins and hence remains confined to the vascular system. It is found to be safe and non-toxic in children. So the most common presentation is a leukocoria, and the child can even present with strabismus, painful red eye, phthisis bulbi and even proptosis. So lacking in knowledge, very few studies are there in these treatment modalities, and most of the studies are retrospective. No comparative study has been done between TTT and ICG TTT. So no study has also reported the usage of ICG as the primary or upfront treatment modality for the treatment of tumors. So rationale of the study, retinoblastoma is a non-pigmented tumor, while absorption of TTT is better with pigmented lesions. ICG is a chromophore with similar light absorption spectrum as that of the wavelength of the TTT diode, hence must augment the effect of TTT. Larger sized RV tumors may not adequately respond to TTT, and thus ICG enhanced TTT may reduce the number of focal treatments required for the thicker tumors as compared to TTT alone and achieve a greater tumor height reduction. So primary objective was to evaluate if ICG enhanced TTT achieves greater tumor reduction in tumor height as compared to the TTT alone in retinoblastoma, and the secondary objective is to compare the complications rate between the two groups. We included tumor height more than 2 mm, largest basal diameter less than equals to 10 mm, tumor not involving fovea, clear media and willing to give consent. And we excluded the tumors involving fovea, any media haze, any calcified tumors or not willing to give consent. So it was a randomized controlled trial done in Dr. RP Center for Ophthalmic Sciences with a study duration of 1.5 years. And the study group were group 1 and group 2 with 14 tumors in each group. Group 1 TTT alone and ICG TTT in the group 2, and the ethical clearance was obtained. So this is the basic methodology, the clinical workup of the patients, and the examination under anesthesia. We noted all the tumor parameters. So all intraocular RD eyes that require the chemo reduction were prospectively included after 2 cycles of chemotherapy, and focal treatment continued for next 4 consecutive UAs or till tumor achieved a height of less than 2 mm. So these are some pictures. Laser indirect ophthalmoscope, the transpupillary thermotherapy and the ICG dye. So this is the basic procedure by which it is done. So data analysis was done with the help of SPSS, and statistical tests applicable were applied. So these are the baseline characteristics in each group which were comparable. Same with the color of the skin, presenting a plain and eye, and also the ICRB group and the tumor location with a slightly higher in tumor parameters in ICG TTT as compared to the TTT group. So there was a significant difference between the two groups in terms of change in the tumor height in the 4th session, with the median change in tumor height at 4th session being highest in the TTT group. Same goes with the percentage change in the tumor height. As we can see, in the ICG TTT group, it caused a tumor reduction of 44%, whereas in TTT alone, it caused a reduction of 21%. So this is the summary of the change in the tumor height and the percentage change. So these are some clinical pictures in which the first is ICG enhanced TTT where complete scarring was seen, and the second is TTT where fish flash regression was seen. So both the side effects in both the groups were comparable, and there was no significant difference. So the combined use of ICG and TTT in thicker retinoblastoma has showed clinically significant reduction, and there was no significant difference between the two groups in terms of distribution of side effects. So to conclude, the combination of ICG with TTT is a potentially better treatment modality in terms of treating thicker tumors in retinoblastoma as compared to TTT alone, but the limitations is small sample size and small duration of follow-up. So we recommend the combination of ICG dye with transpupillary thermotherapy appears to be a relatively better treatment modality as compared to conventional TTT and needs to be explored further in thicker intraocular retinoblastoma. Thank you all for your patience here.